Thank you very much. Dan has been an inspiration to me for the past several years since he joined SHAPE, along with our esteemed colleague, Dr. P.K. Shah, who we're missing, and I'm hoping he will join momentarily. This picture, I would like to start with honoring the main outline in this presentation, late Dr. Ward Cassels. He was my mentor at the University of Texas, where I grew up academically under him, and later under Dr. James Willerson. Dr. Cassels and Dr. Falk and Dr. Shah were with me in the first SHAPE symposium, which was 11 years ago, a little over 10 years ago. This was our first one. At that time, we called it VP Symposium, Vulnerable Plaque Symposium. And as you can see, the first speaker is Dr. Falk, who is also among the speakers today, and a number of others, including Dr. Shah. So we have come a long way over the last decade to do one thing, to the least, and that's to raise awareness on advancing, the need for advancing the status quo for primary prevention and early detection of asymptomatic high-risk individuals, which we collectively call the vulnerable patient. The vulnerable patient is a spectrum, and over years, as you can see on our SHAPE website, it evolved from vulnerable plaque to vulnerable patient. Our turning point was 2007, where we gathered a large group of leading cardiologists to make the transition that we're not just looking for vulnerable plaque. There are many vulnerable plaques, possibly, and there are more factors for vulnerability than just plaque. Blood related factors, as well as myocardium, so we defined vulnerable patient, and there our challenges started. So how do we find the vulnerable patient? The vulnerable plaque could be possibly detected in the cath lab when you have a patient came to the cath lab and look for those, but the vulnerable patient is asymptomatic. So the SHAPE movement transitioned to a much bigger effort to identify asymptomatic vulnerable patient. The asymptomaticness takes them completely outside of cath lab, in fact outside of most cardiology practices. So SHAPE suddenly became a primary prevention, family physician, and early detection type sensation. We raised awareness. We were praised by some and attacked by others. Matt Budoff was our face for a lot of taking bullets, as well as taking some interviews, but I think we all as a group came out truly to our value, that we were about nothing but raising the level of care for identification of the vulnerable patient. So with that introduction, I'd like to just walk you through quickly the slides that we have and identify the problem one more time, because the entire session today will be all about attacking the problem. So what is the problem? Well, the problem is this. We have a pandemic of atherosclerotic related, predominantly cardiovascular disease. As Dan Berman always put it in his talks, is that the saddest part of this is most of it can be prevented. You can't say that about a lot of cancers. I don't know if you could have prevented melanoma in Steve Jobs. I don't know if you could have prevented prostate cancer in Dr. Ward Cassels. I don't know how well you could prevent it. But most of the cardiovascular, heart attack related, and stroke related could have been prevented or can be prevented. And unfortunately, we're losing lives, productive lives, to those clinical findings, heart attack and stroke. But both of those clinical findings, common denominator or the actual pathology is one thing, atherosclerosis. I mean, cancer has 100 different types of pathologies. You can never really treat one cancer with the same as the other one. But with atherosclerosis being the denominator of all of these major acute events, we have the opportunity. So that was the problem, and the magnitude of the problem is most predominantly visible in those who are victim of sudden cardiac death, because they don't even have a chance to get any of the benefit of whatever has been developed in years here at Cedars-Sinai or at Stanford or at Harvard or Hopkins or at University of Texas for the advancements we have made in treatment and further expanding the life of those who are affected, because there are just sudden deaths. We have, by definition, 1 hour from the onset of symptom and they die. It's about 250,000 of those. Unfortunately, that number is not going down. That number, despite the fact that general CVD incidence is going down, the number of sudden cardiac deaths has not gone down. In fact, it is shown that it's increasing in women. Sudden cardiac deaths, dying within 1 hour outside. So that problem remains the biggest problem. So where are we with SHAPE and the status quo? This is a slide that I've made based on the largest study I've seen, 136,000 individuals, according to American Heart Association's Get With The Guidelines database that was published several years ago by Sativa and colleagues. And this slide shows everybody who came to emergency room. If you look at their LDL level, and they were diagnosed coronary artery disease patients, 77 of them had normal meaning LDL less than 130. If you put the LDL less than 100, it would be lower. But this group, if you break them down, those who were treated with a statin or had a prior event and those who didn't, the number changes only 7%. So there was a question that how are we saying that these people have normal LDL, they might have been treated, but if you split it down in treated group, it's only 7% difference. So the bulk of people who come to emergency room or come with an acute event have average or normal risk factors here, LDL. Well, the same story is true for HDL. The HDL level in this large study was about 45% of them had normal or average HDL. The same thing for triglycerides. So these are the main ingredients of what we measure as Framingham risk score. And the most visible study that I've always referred to is this study that basically tells you if you take the most productive part of our society who are affected by heart attack, who are those people? There are people who are aged less than 55. They are not disease patient, they don't have history of disease, they might have hypertension, they do their life as usual, exercise and possibly taking some medication. But if you look at them, and this is a study actually on individuals who had a heart attack. So we're trying to replicate this in a hypothetical scenario. Take the time back with these individuals and say, let's go a day before their heart attack and run it by the existing guidelines. Tell us how many of these people who are going to have a heart attack tomorrow will be detected as high risk the day before. Ideally, in Matt Budoff's facility where he practices SHAPE, at least 90%, hopefully 95%, because we're looking at those people who have plaques, and if they have plaques and the severity of plaques is higher, their risk will be higher. But the status quo does not practice based on presence and severity of atherosclerosis. The status quo, which is the NCEP guideline, practices based on the number of risk factors that they have. Well, look at that, and then let's walk through this. So the two questions: what percentage of these people who are going to have a heart attack tomorrow are going to be high risk, detected high risk today, and what percentage of them are going to qualify for treatment? Three categories, as you all know: high risk, moderately high risk, and low to intermediate risk. This group is not going to get any raised flag or alert or ambulance attention. The doctors are not giving neither a patient if they fall in this category. This group is where you want, as I said, 90% of them to show, and this is the intermediate risk. So let's walk through this. Again, this is a group, actual patients. This is not hypothetical or theory. I'm turning it to a theory, saying turn the clock back 24 hours, run it by the existing guideline, see what percentage of them are high risk. Total is shown in white. Those who qualify for statin therapy, red, and those who would not qualify for statin therapy is yellow. Let's see. Only 12% out of this whole group of people who are going to have a heart attack tomorrow, according to this study, based on this characteristic: no diabetes, no prior history of coronary artery disease, age less than 55, very productive part of society. Only 12 of them, and half of them were not even qualified for a statin therapy. 18% of them fell in the intermediate risk, or moderately high risk. And out of those, only 10% qualified for therapy, and 8% did not. And this is the biggest part of our problem. These people who are going to come with a heart attack tomorrow, according to existing guidelines, 70% of them are not characterized as high risk. Therefore, they are not going to get attention because we just looked at the risk factors. If we were to look at their atherosclerosis and their burden of plaque and their intensity of disease, the story would have been different. This can summarize SHAPE and what we've done in the past decade. Conclusion: relying on risk factors of atherosclerosis is misleading, is not sufficient. A direct assessment of the disease, which we call atherosclerosis, is needed. I have a dramatic picture. This is not meant to specifically go to his background and his family history or his personal lifestyle, which is Jim Fix, a very distinguished marathoner who should be credited for moving America to streets and running, versus Winston Churchill, who did all the bad things and carried all the risk factors along with his cigarettes and cigars and whiskey, lived a much longer, almost twice as much as Jim Fix. I give credit to John Rumberger, a good friend of us, we're missing here, for putting this together years ago, and this stuck with SHAPE just as an illustration that risk factors and relying on the outfit, whether you are overweight or you have a sedentary life or you smoke, is not enough. Sad part is when it comes home. Home is where cardiology and cardiologists are. These two distinguished cardiologists from Germany, sadly, were victims of the same sudden cardiac death and atherosclerotic event as Jim Fix was. I think the message is very clear. I don't need to explain, and that is this. And these gentlemen were not SHAPE advocates or practicing SHAPE. I can only guess that if they had gone through the SHAPE practice that my good friend Dr. Raymond Erbel has been advocating in Germany for decades, at least 15 years, I remember, I bet they would have saved their life and would have been a better example of the cardiology society where we're after eradicating heart attack. Heart attack is a failure. Heart attack is a metastatic cancer, a stage 4. Should not happen if you did your job as a cardiologist. So that's to say that a status quo is unacceptable. And what we are dealing with is a pyramid like this, which was drawn again a decade ago as part of the SHAPE movement. The bottom of this pyramid are 140 million in this country, only America. Expanded to Europe and the rest of the world, you get the same picture. Half of the victims come from asymptomatic, apparently healthy individuals. The other half comes from those who had the first event and are repeated coronary events. So we put together from vulnerable plaque to vulnerable patient, call for new definition, risk assessment strategies. As you can see, this was published in 2003. We expanded to part 1, part 2, and along with many of you as speakers and other distinguished cardiologists and leading researchers over years, most notably the event that happened, the historical event that happened in 2 days behind the locked doors at Santa Monica Marina del Rey hotel, where we put our brains together and our egos aside to come up with a common understanding of how to go and tackle the problem. And that was the SHAPE guidelines. It was published in the American Journal of Cardiology as the part 3 of this consensus. And you will hear from the speakers how SHAPE distinguished itself from the status quo. The status quo is saying, do screen risk factors and stop right there. Treat people based on their risk factors. This was not enough for us. That's what SHAPE went after, going screen for atherosclerosis, which is the disease. It's asymptomatic, but it is a disease. And regardless of risk factors, even cholesterol is normal or average. And treat based on the presence and the intensity of risk factors. So if you are taking one thing away from today, or those of you online, this is the message of SHAPE. And many believe that we have enough evidence to practice SHAPE. On the other side, the academicians could argue that we don't have enough evidence to practice SHAPE because we never done a randomized longitudinal study of letting people do what they do in the normal conventional way and the atherosclerosis-based detection and treatment. Because we haven't done such a trial, we can't recommend SHAPE universally. We respectfully disagree. That academic approach, we believe, has holes in there, and that argument you will see from many presentations today that could be canceled. However, we're not against doing such a trial. In fact, SHAPE called for such a trial in 2006. We invited the NIH and leading figures at the NIH level to come and participate in such a trial with the help of SHAPE to design it. We were shut down or rejected. 2 or 3 years later, we found out that NIH recognized the importance of doing such a trial after 2005-06, which was raised by SHAPE. And we're happy to hear that Dr. Budoff from SHAPE team is involved in designing such a study. That's going to be a very expensive study. So what is, again, summary is that SHAPE went through studying a number of methods of evaluating presence of atherosclerosis at the structural level and at the functional level versus risk factors of atherosclerosis, which you can see from recent literature. The number is growing with genomic and proteomic markers coming in and biomarkers. But we believe those, though important, cannot replace looking into the artery, seeing the presence of plaque, and looking the response to therapy by monitoring the function of the artery. So this was set forward from the first SHAPE task force. Message is very clear. Nobody should be excluded. Apparently, healthy individuals should be screened. We further narrowed that by putting some limitation, but that we only did it for cost effectiveness. And that cost effectiveness comes to the policy level, and it's important. Where do we go from there? We do the atherosclerosis test, and that's what we need to define what those tests are. We'll hear today. If you're negative and you don't have risk factor, we hope that you, or we believe that you are at the lowest risk. And if you're positive and you have the maximum level of plaque burden, you would be the very high risk. This, as simple as it sounds, is not practiced today. We still look at people's cholesterol, assuming high cholesterol translate to high burden of atherosclerosis. We do have the technology to look into. This is a more in-depth definition of the SHAPE guidelines and the steps, and those who would be excluded here. No insult to individuals over 75. We assume that the productivity and the cost effectiveness is not much in that society, in that part of society, to recommend widespread screening. But I personally believe nobody should be excluded. This is my individual. If it was my dad and he's asymptomatic and I want to make sure that he gets the best care and he's 76, I would want to know if he has plaque in his coronaries or his carotid, and how much plaque does he have. Again, I'm not going to go into this because we're going to discuss this in length throughout the day. The last SHAPE task force meeting opened the discussion, did not close it, opened the discussion that we should consider reshuffling the two atherosclerosis tests, the carotid and the coronary calcium test, for their availability and the cost and the radiation. All of those will be discussed today. So that's one. This is the group who really pushed the SHAPE guidelines out, and we're missing some of those today. John Rumberger and Zahi Fayyad are not here. The rest you will see momentarily. So is it enough just to come with the guidelines and leave it to the society? We don't believe so. We believe the practice of guidelines needs to be facilitated by healthcare policymakers and legislators. We didn't really have an initiative on our own. We were contacted by a congressman in Texas that I'm going to show you, who was personally affected. And we showed him that comparing to other diseases, cardiovascular has the highest toll on our national budget. But when you look at our national guidelines for spending money on prevention of these diseases, you will see very clearly that there is a huge imbalance. The imbalance is that for the number one killer, we approve somewhere around $100, less than $100 of our budget for screening. For number two, cancer-related disease, we have more than 1,000. This is our tax, you and I and everybody else who pay tax in this country's allocation for prevention of cardiovascular disease versus cancer. So we did some efforts behind the legislative proposal. We fought it through academic argument, publications that you see. The bottom line was that in the state of Texas, we now have the first heart attack preventive screening legislation, which became law and is practiced. It's not widely practiced. We found that insurance companies quickly learned their way around the law. So there is a big loophole that we hope to be fixed, and that would increase the adoption of SHAPE guidelines. And we showed by calculations and hypothetical assumptions that it indeed reduces costs. But it's just, let me make an example. It's not going to reduce costs today if everybody adopts SHAPE, because they're going to go and get tested, and that test is going to cost them some money. And remember, as great as SHAPE is, no test, no diagnostic test, quoting my good friend Dr. Sanjay Kaul and George Diamond, both critical but supportive of our movement. No diagnostic test can save life. We know that. SHAPE is not a diagnostic or a screening initiative. It's the intervention after diagnosis that makes the difference. And that's what we're talking about. So if you do a screening according to SHAPE today, are we going to eradicate heart attack as much as Dan and I would love to see it today? No. It's going to trigger a series of interventions that will lead to reduction of heart attack. And so this is this calculation. Another example of that is just education. You know, not going to go into politics between Obama and Romney, but if you put $1 billion on education today, you are not going to increase productivity today. It's going to turn around 10 years from now or 15 years from now. That's the story with preventive strategies for cardiovascular disease and, for that matter, cancer and others. So we believe that preventive cardiology is the shape of the future, and such an approach would start from people's home, not from hospitals. It starts from people's home. It starts from their retail shops, their Walmarts and Walgreens and family physician offices, and then trickles up towards a wider, a narrower group, but wider range of diagnostic and intervention strategies. So I'm going to land my presentation that SHAPE Society is not a society of a professional doctors who, like Dr. Falk and Dr. Shaw and Berman and Budoff of the world. It's now a public society which represented with the first speaker, as you saw, Dick Hullner, and the group that he's assembling together to take our message to the world, and we look forward to seeing that practice everywhere. There is a book that is contributed by 120 leading cardiologists and cardiovascular researchers who put their name behind the SHAPE efforts. That's the asymptomatic atherosclerosis. And we look forward to seeing all of these efforts translate to one thing, and that's elongated life, improving quality of life, and increasing productivity for the society. With that, I'd like to thank everyone who came so early, woke up in the middle of, I guess, dark, and made this possible. There'll be a lot more on the internet. In the past, we had about 10,000 visitors to SHAPE Symposium presentation, and we look forward to raising that awareness. Thanks so much. I'd like to ask Dick to read the agenda. We have a little shuffle in the agenda. Unfortunately, our featured speaker, Dr. Valentin Fuster, my great mentor, called me yesterday morning because of the storm, Sandy, and all the mess it created. His schedules and life has been adversely affected, so he had to stay with his wife. Apologize to the audience. However, he has a number of surrogates here. I just saw Dr. Jagad Narula walked in, and good to have him. Dr. Harvey Hegg, both of them are from Dr. Fuster's hospital, Mount Sinai. Perhaps more importantly, Dr. Falk, who I believe shared a lot of Dr. Fuster's slide, is going to go for it. So we have a little change in the agenda. Dick will tell you. Please fasten your seatbelts for a SHAPE ride. Thank you.